We're grateful to the Meadows Mental Health Policy Institute for sponsoring this panel on mental health policy in Texas. I'd like to introduce Tom Luce, who's the consultant and founding president of the Meadows Mental Health Policy Institute and CEO of Texas 2036. So Mr. Luce will be moderating our panel, and he'll be introducing our panelists. So panelists, if you'd like to come and sit, and thank you very much. Thank you so much.
Thank you. Good morning. Thank you all very much for the privilege of moderating this panel today. It's a real honor and a thrill to be here today. Peter O'Donnell is a longtime friend of mine. I first met Peter in 1961. I was 2 and he was 6. But we became childhood friends, and I remember very distinctly, I think my job was to transcribe his notes when he conceived of this organization many, many years ago, and he would be thrilled to see what has happened with regard to this organization, so thank you. And I'm so pleased to be able to talk today about and really moderate a panel of experts in the field of mental health policy. To set the stage for the conversation, I wanted to share with you that we formed the Meadows Mental Health Policy Institute about 6 or 7 years ago because of the growing awareness that we really could not address the, quote, healthcare needs of the people of Texas unless we paid more attention to behavioral health and the integration of behavioral health and physical health. And that led to the creation of the Meadows Mental Health Policy Institute. And I think through a variety of factors and a growing awareness in the public of mental health needs in our state, there is a tremendous amount of momentum that has been created to begin to address the very complex issues of how we really deal with these issues that impact so much of our healthcare system. And because of that, I think we're at a critical juncture in the current legislative session in the progress of this. And one of the overriding issues is how do we better integrate research and academic involvement into this whole field, because we cannot address long-term these issues unless we deal with these issues in the ways that we have historically dealt with other aspects of healthcare. That's the reason for this panel. These are the people that are really the experts, and I want to start. Each of them will have the opportunity to set the stage for future questions, discussion, by starting to lay out for you about 5 minutes from each of them about what they're working on. They're all actively involved in these mental health policy issues. And I'll start by introducing the first panelist, then he will introduce subsequent panelists. And the first person who will be talking is Dr. Andy Keller, who I had the privilege of meeting when I formed the Meadows Mental Health Policy Institute. He's a wonderful professional who had been doing policy work all over the country and was persuaded to move to Texas to lead the Meadows Mental Health Policy Institute. Andy has been a leader in that effort from the beginning and has managed somehow to build a network of professionals all over our state, and I think he can best inform you as to what are the current issues that will be addressed in the coming legislative session, and most importantly, how the academic institutions of our state are beginning to rally to really address some of these issues. So Andy, why don't you step forward?
Well, thank you, Tom, and thanks for being here today, everybody. I want to tell just sort of a story to frame the discussion today, to kind of say, where do we need to go with policy in Texas when it comes to psychiatry and mental health services? And it's really the story of two state-run hospitals. One of those state-run hospitals, and Dr. Lakey is going to talk about this in more detail, is the Austin State Hospital, which is one of the places in the state where we care for folks with severe psychiatric needs. One cool fact about the Austin State Hospital is it was built in 1861, which some of you may recall from your history classes was also the year that the Civil War started. And this was 6 years after a woman named Dorothea Dix in the mid-1850s helped form the very first psychiatric hospital, which was a big innovation in the time. It was what you might call evidence-based care, or at least as close to that as we got back in the 1850s. And it was a step forward from being able to care for people in jail. So keep that innovation in mind. That's one state-run hospital still operating in that building that was built in 1861, as well as a couple other buildings built since then. And a building that was, a set of buildings that was recently in a report 3 years ago described as not even salvageable, and the best building option would be to bulldoze it and to build a new one. So that's kind of the state of that hospital. The other hospital, state-run hospital, is one that I was in San Francisco 4 years ago contemplating, actually 5 years ago, contemplating the move that Tom mentioned about coming to Texas, super excited about it, was there with members of my consulting firm I worked with back then, planning my transition out. And I'm in San Francisco and I see an advertisement for a state-run Texas hospital. And now this hospital is one called MD Anderson. And that's another state-run hospital. It's a state institution, but it's one that is a leading research institution in the world. It's one that has buildings built since the 1860s. I think actually all the buildings have been built since the 1860s. And it's one that is fueled by world-leading research, world-leading clinical care. So how do we bridge the gap? And that's really what we're trying to do here at the Meadows Mental Health Policy Institute, is we want Texans to have the same level of quality in their mental health and psychiatric care that they have in the rest of their health care. That's all we really want. And so the way we do that at the Institute is we really look at that connection between state policy and local systems, because nobody gets their health care in Austin unless they live in Austin. And so the Austin State Hospital is one that has the potential, and you have senators like Senator Watson, who've taken a real lead to help get the Dell Medical School built there, that's helped build a real vision for how that medical school could be transformative through its research, its training, and its clinical care for its community. And that's the kind of thing we need in Austin. But Austin, that hospital actually serves over 50 counties that go all the way down to Galveston. And if you're in Galveston and you have a psychiatric emergency, on your way, being driven often by a sheriff's deputy, to the Austin State Hospital, you pass the Harris County Psychiatric Center, and you pass a bunch of other community hospitals, and then we take you to Austin. Now, one of the evidence-based terms we have for that type of system design is, well, there's actually a lot of terms I probably shouldn't use, but it's not actually the best system, and it's not hard to see that. And this diagram kind of lays out in a pretty simplistic way the differences in how we organize things like medicine for cancer versus medicine for mental health. For cancer, my mom was treated for breast cancer 6 years ago. She wasn't discovered in an emergency room because we no longer wait 8 to 10 years to treat cancer after symptoms emerge. It was probably 8 to 10 days after her breast cancer began to develop when she first felt it, doing a self-examination at home, and she was able to go not to an emergency room, she didn't call the police, she went to her primary care doctor, her OBGYN, who helped her kind of figure out what the next steps would be, linked her to an OBGYN, linked her to an oncologist, and she had surgery and chemotherapy and radiation without ever going into a hospital. That's the current status of care we have for diseases like cancer. For mental illness, we typically wait 8 to 10 years, and what happens a lot of times is at a point of crisis. Our point of detection is there's a crisis bad enough for us to call law enforcement. And that's our front line, and that's how our system was developed. So as a result, we have, and this is just an overview of some data, but if you look down on the line of schizophrenia specific diagnoses, we have about 100,000 people in our state living with schizophrenia, most of whom are not doing so well. However, every year, we'll have only about 2,000 new cases of psychosis. By waiting on average 2 to 5 years for the treatment of psychosis, we end up consigning people to a lifetime of suffering, a lifetime of unreached potential, and a lifetime of difficulty simply because we don't intervene in time. What we're going to talk about today are some policy changes that are allowing our leading medical institutions in the state to have more of a direct involvement with our mental health system and to try to change that tide so we get to the 2,000 rather than the 100,000. And before I stop, I just want to say this is doable, folks. We actually believe that we can treat every woman in Texas who has breast cancer. That's a commitment we have. We actually try to do that. We do not today try to do that for psychosis. And we need to do it because you know what? There's only 2,000 new cases of psychosis every year. There's 16,000 cases of breast cancer. If we can muster the will to do something for breast cancer, we can just take that same will and do that for mental illness. And that's really the genesis of all the policy things we're going to talk about today. I want to introduce next our colleague and I think a friend, Dr. David Lakey, who I think more than any other person in this state has helped move our leading medical institutions further into alignment and partnership with our public mental health system and our broader mental health system. So Dr. Lakey was the former commissioner at DSHS, led our public health system of the state. He's now Vice Chancellor for Health Affairs at UT System, and I'm just thrilled to have him here today. So Dr. Lakey's going to come and talk about this as well.
Well, thank you, Andy.
We'll leave that there for Carol.
Well, good morning, everyone. It really is a privilege to be here today and to share some of our thoughts related to some opportunities to really improve the mental health system here in the state of Texas. And whenever I talk about mental health, I tell folks that I kind of came into this arena through the back door. I am not a mental health specialist for training. I'm an infectious disease physician who worked out in East Texas, then somehow became Commissioner of Health and ran the state health department for 8 years. And I knew about the infectious disease, the public health issues, but the way DSHS was designed when I was at its helm was we were also the mental health agency for the state of Texas. And so all the state mental health hospitals reported to me, the community mental health services, and the substance abuse services. And so I got to learn through my staff the challenges that we have with mental health here in the state of Texas. The state mental health hospitals, they were designed as penitentiaries in the 1800s and then were converted into state mental health hospitals. And I got to walk through each of those state mental health hospitals, and it was just wrong. There's something that hits you inside when you walk through those hospitals, when you have 6 people in the same room. I couldn't imagine my son, my daughter, or myself in that room if I was paranoid and sleeping in a room with 5 manic people, how I would heal if I couldn't sleep. The way that they're convoluted as prisons so you can hide in different areas, that they were designed because people went there and stayed there for the rest of their lives. They were 90-acre campuses with baseball parks, gardens, and cemeteries, because you basically went there and lived there for the rest of your life until you died. On the community side, we had significant wait lists, couldn't get people into the services. We had, the jails have increasingly become the de facto mental health system in many ways for the state of Texas. And we decided we needed to work on that. And working with the legislature, and the legislature has been very supportive in trying to address these issues because they hear from the constituents. And so significant resources have been put in on the community side to address the wait lists over the last several years. We've been able to build out community hospitals in the state. Our thoughts is we ought to be able to, if my kid was hospitalized, I'd want him to be in a hospital that was close by so his pastor or priest, youth workers could come and see them. But right now we ship people off for long distance. So we've been trying to build additional capacity in the community. So as I was leaving DSHS and as we looked at how do we address the hospital issue, we asked the legislature to direct us to do so. We had a rider put on our budget to develop a strategic plan for the state mental health hospitals. And the results of that strategic plan was basically 5 of the 11 hospitals were beyond repair. You needed to bulldoze them over and get a crane and build a new hospital. These are 300-bed facilities in the state of Texas. And because of that need, we decided that we would pull together all the chairs of psychiatry in the state of Texas and the state agencies that were working in mental health and figure out how do we work together and collaborate to try to improve this dysfunctional system. And it was interesting, and Carol can talk about that. It was the first time we brought everyone together. Folks really knew how medicines worked, pharmacodynamics, how to take care of individuals, but the mental health system, the public mental health system, and how do we couple with that in academia is really a void here, I think, in the state of Texas. And so bringing that group together every 2 months for the last 3 years now, that group, working with state agencies, have developed some real tangible ways that we can improve the mental health system. Let me give you just one example. You know, we talked about telehealth, and we had a presentation about telehealth, and we had the state agency talk about how they have challenges of bringing in physicians into these rural hospitals. It was a quick partnership, and very rapidly we were able to get the state to fund 2 psychiatrists in Houston to provide telehealth services up in Wichita Falls, and travel up there once a month, be part of the medical staff, but then provide services in Houston. And the state saved money, Houston was able to add capacity, and we were able to improve the quality of care. And so it's that kind of insight you get when you bring these people together and you get them to start to collaborate. Over the last year, we've looked at the research status related to mental health in Texas, and we're falling behind the rest of the nation. Only a fraction of the dollars that go into mental health research from the federal government come to the state of Texas. And so we think there's an opportunity to do better. So we've been working with this distinguished group to develop a research framework, identifying the priorities that the legislature would like us to work on: depression, bipolar, first episode psychosis, the substance abuse, and the community mental health system, and how do we improve the systems of care. And so we've been working with this, and that gained the attention of the legislature. And so you'll see the Senator Nelson will talk about this, has put in a bill to help support this work, working with the Meadows Foundation, of how do we really move that research agenda forward. And so our Senate Bill 63 is based on that partnership, looking at how do we use the academic centers to provide psychiatric services to schools in their community. You know, how do we work with the local mental health authority to expand educational experiences for our residents. And third bucket that we'll talk about is how do we really move a research agenda forward, like CIPRIT has done for cancer, for mental health, so that we will be prepared to secure more of those funds here in the state of Texas. And I look forward to discussing those issues later during the panel. Thank you. So it's my privilege to introduce Carol Tamminga. I don't have a formal bio here, but Carol is the chair of psychiatry at UT Southwestern, is really esteemed in the area of psychiatry, not only here in Texas, but across the nation, member of TAMEST, and she has been one of our leaders as we've been working together with the 12 chairs of psychiatry across the state of Texas and the state agencies, and has been able to move UT Southwestern forward. We were just talking a little bit ago, a 40% increase in, I think, clinical volume because of the need and the great work that they're doing at UT Southwestern, trying to meet the mental health needs of a major metropolitan area. And so my friend, Carol. Thank you.
I'm here to say that academic medicine in Texas is ready to step up to the challenge of a collaboration of the kind that you've been hearing about. Let me just see a minute. So my position is I'm the chairman of psychiatry at UT Southwestern in Dallas. And having the opportunity to get together every other month with David Lakey and with the rest of the chairs of psychiatry in Texas has been a very seminal event in pulling all of our departments together. I should just say that as a consequence of this, we all knew each other, and we just were successful in submitting a federal grant all together, all of the, a federal grant around the treatment of psychosis. It's not only the chairs, it's not only the academic medical centers in Texas that are ready to do this, but the field itself is ready to do this. The work that I do within serious mental illness, psychosis, depression, drug addiction is really a psychosis research. And psychosis research is somewhat least understood. We know psychosis is not generated by demons anymore. And we're having an increasingly firm idea about what the neurobiology of psychosis is. As soon as we understand what the basis of psychosis is, of course, we can work with drug companies to make new treatments that are specific for the illness. Nonetheless, and in addition to that, we now have new evidence-based treatments that are good. We're finding the pathophysiology for the psychiatric disorders, as I've written down here, in schizophrenia, in depression as well. Schizophrenia is what I know better than anything else. As a part of some of the research that we're doing in Dallas in a collaboration around the United States, we're taking a look at the diagnoses that we've had in the past. Of course, psychiatric diagnoses were based on phenomenology. They were based on how patients present. We had schizophrenia, we have drug abuse, we have recurrent depression. Now, these definitions are not based on brain biology because we didn't have any mechanisms 50 years ago to really understand brain biology. Now we're doing that with the kind of tools, some of the tools of which we heard about yesterday, the fabulous tools. We're using some of the genetic techniques that people were talking about, and we'll be able to define database diseases within the decade, and then have an understanding of our diseases, much like cancer has an understanding of their diseases. There are new treatment directions that we're already using here in Texas. Early detection and early treatment is really a phrase that I find myself saying over and over again, really emphasizing what Andy just said a little bit earlier. We're trying to take those 2,000 people, the 2,000 new psychosis cases in the state of Texas, and do and implement an evidence-based treatment program around the whole state in the five major cities, actually, and try to take the 2,000 young people and turn their lives around before they head downhill. For those of us who were here yesterday and had the opportunity to hear all about the fabulous techniques, reminds me to say that we now have the possibility of personalized psychiatric treatment using stem cells, using organoids that we heard about yesterday, and finding treatments that are really selective for people. Not that we can do it today, but we will be able to do it in the future. And this is the kind of goal that I think is important and useful in psychiatry. Texas hasn't had a lot of psychiatric research before, and we've never had, before the group that David Lakey got together, we never had a lot of collaborations amongst the psychiatric centers in the state. But now we know each other, we have ways of talking to each other, we've developed goals and directions over the years, and now we're really ready to start. And the federal government might actually give us money. We'll see in February to do some of the early detection and the early treatment in the area of psychosis. There's a lot left to do. There's a big opportunity in Texas, and the opportunity, one of the aspects of the opportunity is that we haven't done it before. Texas hasn't done it before, so that there aren't entrenched pathways. We can really develop the pathway that's really most useful for us in the future going forward. With that, I'll turn the podium over to Tom. I don't need to introduce him.
Thank you all, and again, what is so exciting for me is that, to me, what is beginning to happen in mental health in our academic communities is really what Peter and Edith O'Donnell envisioned in helping to create this organization, and that is, if you get the best and the brightest minds in the academic community focused on research and how to address these issues, great things can happen. And that really is beginning to happen in the mental health field. And if we can embrace this movement, it will have enormous consequences in our state. And I really do believe, and normally in Texas, often we we say thank God for Mississippi because sometimes we're ranked 49th in categories. But I really think in mental health policy, Texas is really beginning to shape the future of how we can involve the academic community and the more traditional physical health care institutions into beginning to move towards integrated health care. The fact of the matter is, most people, our system today says if you have, quote, a mental health problem, go over here to the right, and if you have a physical health care problem, go over here to the left. Well, guess what? Most people are dealing with both, and we are moving gradually and hopefully with progress towards an integrated healthcare system that says you have to address the needs of both, and they both emanate from the brain, which goes back to Peter and Edith O'Donnell. So I really think this is a seminal movement that is occurring in mental health, and it's going to be led by, if this world is going to change, it's going to change because of the leadership of research and academic institutions. And that's really the challenge we want to present to you all today. And I think the best way to facilitate discussion of some of these things is open the floor to questions that you might have of us. And let me say that we'd be happy to respond to any of those questions you might have. As they've laid forward, there is an aggressive legislative agenda that the state is going to consider this year, including, we hope, the Senate budget came out yesterday. As David said, it's going to add $300 million. We hope it will be more to improve our state mental hospitals. But there have been dramatic increases in the expenditures of meeting behavioral health needs, because the reality has been that people have finally discovered. In fact, I served on a Sunset Commission, I think it was 5 years ago, and we made the determination the state was spending at the time about $6.5 billion on mental health in the state. Unfortunately, most of that money was spent in jails. And in terms of, in effect, using Andy's analogy, dealing with people that were in stage 5, not stage 1. And so the whole aspect of understanding how the state has to deal with this issue in a way that not only reduces the individual suffering, but addresses the needs of healthcare cost in our state. There is a growing awareness in the legislature, and the legislature is open to responding to this issue, but it needs the leadership of the academic community, because we can't just continue to do what we've done and really move the needle. So it's a challenge really to everybody in this room to help us address, but the timing is right. This is beginning to occur. Let me open it up for questions and see if we have any from the floor from this distinguished panel. Yes, sir.
Clearly, clearly you've made major progress in thinking out the role of hospitals, but the workforce issues seems to me are profound. Texas is, I believe, has 58% of the national average of psychiatrists. Clearly, not only do we need more psychiatrists, both adult and children, but we also need other healthcare providers who are sophisticated enough to work in this format. What are your efforts? In terms of this package, what are the elements of it that will help with the workforce issues?
Very important question, and let Carol, is Carol, Andy? Carol, you probably the best to address that.
Well, I could just start it, maybe.
Yeah.
And in fact, the workforce issues have been being addressed progressively over the last decade. with the state understanding that some of the counties in Texas don't even have a single psychiatrist in the counties.
174 of the 254 counties do not have a single psychiatrist.
That's right. And the state has been very responsive to academic medical centers like mine, making applications for new psychiatric training, residency training positions and psychology training positions in order to, and telemedicine actually for that matter, in order to take care of people in places where there aren't psychiatrists. And we now have built up not only a large psychiatric resident training program, but a very diverse one. We have a program in rural health, we have a program in psychiatry and internal medicine, and the state has already been very responsive to that. Andy, you want to probably say something.
Let me go, and thank you, Dr. Shine. And again, you have been spearheading the workforce issues here in the state of Texas for a long time, so thank you for that work. I don't think right now we've solved those issues. I think a couple things that I see promising, as we met with all the chairs of psychiatry about a year and a half ago, it became interesting to me that we were detecting early a run on psychiatric residency programs here in the state of Texas. That a lot of these programs bring in 6, 8 residents. They were having 100 people come in to trying to get that residency slot. And so the dynamics have changed. And so I think for lifestyle reasons, pay issues, a variety of things that have changed, psychiatry has become much more attractive to medical students than it has been in the past. I think part of our role also is to influence the Higher Education Coordinating Board when additional funds are made available, that we let them know about the issues in psychiatry. And so we've been able to influence that. And so that more, if you see the most recent allocation of their dollars, it was weighted towards psychiatry. In Senate Bill 1 that was released yesterday, Senator Nelson put in $157 million for healthcare workforce, which was a $60 million increase. And again, I think we need to influence that. In this initiative that we have working with Senator Nelson under Senate Bill 63, she put in $100 million as her starting point for this collaboration. One component of that has to do with workforce, and the model that we'd like to use is based on what they've done at UT Southwestern for the last decade, where they've been able to partner with the local mental health authority by putting a staff psychiatrist from UT Southwestern into the local mental health authority. They can use that individual and add residents into the local mental health authority, and they train there. And so some of the funds will do that. And this is an evidence-based program, because when we look at what happens when UT Southwestern does this, and then look at the career paths of the individuals that had that experience, they're much more likely to go into public mental health service than being cash-based psychiatrist in the state of Texas. And so that there's multiple layers to the mental health component, psychologists, social workers, et cetera. But I'm seeing some headway with the changing dynamics and some funds here that we can influence to be able to address some of these issues.
And I would just add that there were some actually complex policy issues that had to be addressed before you could see that $60 million increase and before you could see the training piece that Dr. Lakey talked about being added to the budget. And I want to just highlight 2 of them. And they're not rocket science, but they're multi-determined. So we went out 4 years ago, and at that time there wasn't this consortium that Dr. Lakey had put together of the 12 departments, so we actually had to call all the training directors of the psychiatry departments, and we had to say, we asked them, if you had unlimited dollars, if you had like $60 million, let's say, earmarked for psychiatry residency, how many more residents could you add? And we needed them to say about 100, because we graduate just over 100 residents a year, both child fellows and regular residents, and we need about twice that many. So it's a pretty big leap. It's not, insurmountable, but it's a big leap. So we were very underwhelmed to hear that their big number was 11. And so we said, okay, why? Why is it just 11? Remember we said you have unlimited dollars. You have infinite dollars. How can you only come up with 11? And they said, well, we need somebody to teach. We need a building for them to be in. We need office space. We need infrastructure. And so we investigated that. How do you build infrastructure? You get research, you do clinical care, you get partnerships with the community. So these efforts that Dr. Lakey and all of us have talked about, and that Carol talked about, Dr. Tamminga, sorry, I need to be respectful of our actual TAMEST member up here, That's what's critical. The second thing that's critical is we have to redeploy our workforce. Every person who breaks their arm does not go to an orthopedic specialist. We're one of the few professions where we expect the specialist to be the front line. And the reality is most of these conditions are being treated in primary care right now, not very well. Most of these conditions are also able to be treated in primary care. And another wonderful researcher at UT Southwestern, which I apologize for picking on UT Southwestern, but Dr. Madhukar Trivedi has over the last 5 years been showing that he can get equal outcomes in actually just community clinics doing psychiatry, not even fancy places like universities, doing evidence-based approaches with minimal educational supports and supports for evidence-based screening. The state of Massachusetts has been doing this for its pediatricians for 15 years. It's called a Child Psychiatry Access Program. And one of the features that's in Senator Nelson's bill, Senate Bill 63, is to create a Child Psychiatry Access Network in Texas, grounded at our medical schools, that's going to basically be able to retrain our pediatric primary care workforce through doc-to-doc consultation and other methods that have been shown to work to do a better job. So we're going to basically need to redeploy our workforce to get more help, but also train more psychiatrists. And these bills this session really set us up for that, but there was a lot of analysis that had to be done to get us to this point. Yeah, please.
We have
If I could just say one more thing in addition to that, is that most of the psychiatric care in Dallas at UT Southwestern is now team-based care, so that psychiatrists aren't necessarily the primary people. We have psychiatrists, psychologists, social workers, and advanced practice nurses, and the medical students and the residents are being trained with that as the system that delivers psychiatric care.
We have another question.
Probably going to have more of a statement. I think I'm probably going to wish I hadn't stood up here, but I'm glad to hear you're making progress with the attitude of the legislature, but there's a serious credibility problem for your profession amongst the populace, in the sense that those buildings that you were talking about were called the nut houses. And when you were committed to, one of your family members was put, quote unquote, in the nut house, they did not come out. It was not like I had breast cancer and someone chopped a hunk of my flesh off and I went home and recovered and went back to work. They went in there and they never came out. And my brother worked at one of those places, and all they did was to retain them in small, so that they couldn't run out and damage the public surrounding the facility. And they gave them insulin shock and electrical shock and maybe some barbiturates if they were moving too fast. And now, the other thing that's a problem is that perception has been created that you're saying there are no psychiatrists. In Austin, I contend that there's an entire industry of psychiatrists who handle dispensing Adderall to something like 40% or more of the little kids in grammar school, and you don't have to demonstrate, or there's no definitive diagnostic test for whatever it is that's ADHD or what ADHD or so forth. But there is a huge number of people buying those drugs, and there are a large number of physicians' assistants and so forth that are making a lot of money by dispensing them. So there's glad to hear you're making progress with the legislature, but I think you have a challenge relative to the populace as well.
We've undertaken that as well. So, Andy, why don't you address that? Because you're absolutely correct.
You're absolutely right, and thanks for saying that. And one thing I want to just say, first of all, is that this is not unique. Bad medicine is not unique to psychiatry.
Now, wait a minute.
And
you
also,
look around this crowd. And
stigma is not unique to psychiatry. Does anybody ever watch the TV show The Crown? Watch the TV show The Crown? No? You guys don't watch television? It's because you're researching all the time. Okay, there's this popular thing called Netflix, which has TV shows, and one of the popular ones is called The Crown, and it's about the history of Queen Elizabeth. So Queen Elizabeth's father had lung cancer. Do you know when they told him he had lung cancer? According to the TV show, which I think is actually based on facts, 5 weeks after they removed his lung. Why didn't they tell him? Because you died from cancer. Why would you depress somebody? And Tom helped me remember. I was a little younger than y'all were, because I wasn't with you and Peter O'Donnell in the early 60s. I was 9 when Betty Ford came out and told the world she had breast cancer, which was stigmatized. Why was it stigmatized? Because we had bad medicine. We weren't finding cancer in time and people were dying. We got medicine better, and now we have races where people go, try to get the cure. My mom, who's a very conservative Christian woman, was somehow convinced that she needs to touch her breast once a month in a very aggressive way and then tell a man about it because she was able to get better care that way. So we're able to get better medicine functioning. So the Adderall problem is because it's not actually prescribed by psychiatrists. It is some. There are some of the folks you talked about, but most of the Adderall is being prescribed by primary care doctors. Now they are bearing the burden right now, and they're doing bad medicine because that's all they have. Now Adderall works in some cases. There are absolutely people who need that, but it is overprescribed. And one of the neat things we saw in the Massachusetts program is by having these doctor-doc consults and better protocols, we were able to reduce both use of Adderall, but also other things like off-label use of risperidol, things where you've got these tools and you're just going to use them to quell the symptoms. The other thing that we're able to do is to change the discussion around psychosis to the issues that Carol brought up about, which are how do we diagnose accurately, how do we intervene quickly, which isn't rocket science, but is good medicine, rather than the discussion we have right now, which is that's driving our systems, is how do we have them go to the jail less. I mean, that's not a very lofty goal. That's not a real evidence-based goal. We can do that. But what we really need to move is get better medicine happening both in the specialty sector, like Carol described, and in the primary care sector. And once we do a better job at medicine, then we'll begin to change some of those perceptions, which we've earned over the years.
And if I may add, I think your perception about the state hospitals is accurate. And I think that the people try to do really good care, but they have been segregated from the rest of the medical community. And so I think one of the reasons that the legislature has been so supportive is because we don't want to just rebuild new hospitals in a failing system. We want to redesign the system. And part of that is partnership with the academic health science centers across the state of Texas. And so Austin State Hospital, Dell Medical School is the one that's leading the charge to design the new state hospital. The goal is that it'll be working very closely with the Department of Psychiatry there once it's finished. Same conversation in San Antonio, and these will be modern hospitals designed to give modern care to individuals. And not the old model where you went and lived there forever, but a recovery model where you go into the hospital only when you need to be there, but it's complementing the services, telehealth, a variety of other ways to provide services in the communities in which people reside. And so it's really transforming the system.
And that's just a...
Yep.
They have a very different perception if you say my kid is in Indiana.
Absolutely.
That's the reason why. Let me interrupt. That's the why, folks. This is so critical. And just stop for a minute and focus on this. We've been able to persuade prestigious institutions like the Dell Medical School to say they will. So you'll be going eventually to a Dell Medical School institution facility, not the state hospital. That's what we need to have happen, is the academic community stepping up and assuming responsibility instead of creating separate systems is where we housed people and warehoused people. This is a transformative change that we need, that is being embraced by the medical community, but it will take time and support from people like you. I think we better move to the next question.
Yes.
Oh, that's why I have time for one more. Okay, they're now doing this to me, but one more question.
Okay. Harris County Jail has a reputation of being the largest mental health facility in the state. And the transformation of no longer requiring misdemeanor, people accused of misdemeanor to make bail, to put up money for bail, means that it's going to be sort of a revolving door. And it seems like when people come through that door, that it would be a wise policy to have somebody interview them, talk to them, try to find out, what their life is like and where do they, what's going to happen to them, so that you can offer some help and keep them from going back through that door again.
Can I just, that's a great point. And, and that's the group, right, that we didn't reach early. That's the group who, we reached 5 years, 7 years after their symptoms emerged. And there is increased funding for that group. So in addition to the state hospitals, last session, Senate Bill 292 put in place $30 million a year to match with local funds to divert people in exactly the way you just described, sir. But part of how we were able to convince legislators to fund that was we said we're not just going to keep digging the hole deeper. We're going to also try to intervene earlier and cut off the flow, because we have to systemically change what we do. If all we do is wait, we need to do that. But we also were able to say, let's do these earlier things, and the credibility of folks like Dr. Tamminga, like Dr. Lakey, Dr. Strakowski, Adele, being able to show that there is hope is part of how we were able to actually get additional funds for that group as well. And the hope is, I think, really what you all embody here, and that's what's been so critical.
Well, let's give the panel a wonderful round of applause. Thank you very much for addressing all of these issues.